All right. Hopefully we have everybody and we'll go ahead and get started. First of all, I want to thank you for being here at this presentation. I've had a sneak peek at it and it's going to be really wonderful. We've had a very productive morning with a lot of speakers, and so we're looking forward to continuing this. The first thing that I want to mention is I want to thank our sponsors, and without our sponsors, we would not be able to do this event. And so we have board members. We're a volunteer board members, and we want to thank them for their tireless effort. There's a lot of work that goes into producing that. So if you see any of these folks, make sure to say thank you. And so you've had our agenda today, and apparently you understand the logistics because you've made it to this room. So we want to put out a huge thank you, a huge shout out to our program sponsors, because they're the ones that make this possible. So our platinum sponsors are Fortinet, UpDocs, and Cisco. We're very grateful for their partnership and their sponsorship in our work. We also have premier sponsors we'd like to thank: Cover My Meds, VirtueStream, and Nord. And we'd like to thank our lead sponsor, Trinisys. So thank you to all of them, and we appreciate all the work that they're doing and all of you are doing during this time of the pandemic. And so I would like to turn the ball over now to Dr. Ramtekkar, but I'd like to give a quick introduction. He's a highly esteemed speaker. He is an associate professor of psychiatry and behavioral health at The Ohio State University. He serves as associate medical director for Partners for Kids, one of the largest pediatric accountable organizations in the country. And he's medical director of Tele Virtual Health for Department of Psychiatry at Nationwide Children's Hospital. He has been the co-founding director of a statewide behavioral health access program and served as a consultant for an HRSA-funded expansion grant. He also participates nationally in work groups developing policies and guidelines for practice of child and adolescent psychology. And with that, I am going to turn it over to him, and we're going to have a very wonderful and informative presentation. Thank you.
Great, thank you. Thank you for that great introduction, Donna. I don't know if half of that is even true, but thank you. My mother would be very proud of me if she would hear that.
Indeed.
So let me quickly pull up the screen. First of all, good morning, everyone. Thank you for your interest in being here. Is everybody able to see the full slide deck, or is it the notes section that you're seeing?
I'm seeing a split screen.
Are you seeing a split screen?
So I'm seeing your PowerPoint and the slide that comes next, and you.
Okay. All right. Let me quickly try to switch the share. All right. How about now?
Perfect. Absolutely perfect.
Well, wonderful. Thank you. Let's begin. I'm going to just say that the world will never be the same. And there are a few dates that probably we should be thinking about. So these are some of the dates. April 1993, and because it's an audience of HIMMS, I'm sure you know about that on April 30th, 1993, CERN put the www, World Wide Web software, in public domain. And that led to the big expansion and how communication occurs, how media reaches, how softwares are developed, and how web servers are freely available. So the world is not the same after 1993. The similar thing happened in May of 2000. So I think May 1st, 2000, then President Clinton put on an order for effectively removing any restrictions when it comes to global positioning system and its access to civilians. And since then, the whole GPS system and how we travel and what we do on our phones, on our cars, how we plan for all of these long distances, etc., that had completely changed. And the world is never the same since 2000. Same thing happened in March 2020, where Health and Human Services and the OCR put together a statement on March 23rd that we are empowering medical providers to serve patients wherever they are during the national public health emergency. And we are especially concerned about reaching the most at risk, including the people with disabilities and person who are older. And that's the statement of the OCR director. And that catapulted the telemedicine by almost about a decade. And so the world of healthcare now, as we know it, will not be the same again as well. So with that introduction about what we're going to talk about, where do we go from here? Where we are in a middle phase between no longer, but not yet. And so we're going to talk a little bit about that. But first, about us, I'm honored to represent Nationwide Children's Hospital, one of the largest freestanding pediatric hospital in the country. It has been consistently listed in the top 10 pediatric hospitals in the country, and I'm proud to see that every year it's going up on the ladder. But it's not just the mission of providing care, but it's also the research that is very important. And the Research Institute at NCH has been consistently very highly ranked. It's a machine when it comes to innovation, startup companies, inventions, and scientific publication for the dissemination of knowledge. And one of the very unique part about Nationwide Children's Hospital is affiliation with Partners for Kids, which is one of the nation's oldest and largest accountable care organization for pediatrics, started in 2004, when it was not even called an ACO. The concept was very new. And we serve about 34 counties in Central and Southeast Ohio, covering for about 325,000 children. And now very recently, we have partnered with the West Central region, and that is done through Dayton Children's affiliation, and that adds to another 93,000 children. So as the word accountability is there, we're really accountable for their clinical outcomes, but we also take the financial risk. So it's in our best interest to provide the highest quality, value-based care so that we improve the outcomes, but do it in a fiscally responsible manner. That same principle kind of continues with behavioral health as well. While we have been seeing a concerning trend of increasing behavioral health concerns in pediatric population, rapid increase in diagnosis depression, significant uprise in suicides and self-injurious behaviors and suicide attempts, and multiple crises that these kids are going through. With that, a lot of the hospitals, a lot of entities were not able to sustain even the single inpatient units. And while the inpatient units across the countries have been shutting down for children with psychiatric needs, I'm very proud to say that our organization made a commitment for putting together a freestanding, one of the largest, one of its own kind, behavioral health pavilion with the help of Big Lots Philanthropy. It is a full range of service across the continuum of age groups as well as diagnosis. And we work on the same principle and same mission about improving health of children through high value and innovative care. And we're excited now on for the academic research and clinical excellence that hopefully we will see in coming years, as this building just opened right at the time of COVID-19 becoming a major disaster for us from public health perspective, but also provided an opportunity to use that catastrophe to catalyze some of the innovation that we need for continuity of care. And this is our strategic plan that that is available in public domain. But this is mostly around delivering best-in-class evidence-based outcomes, redefining the quality in pediatric care, fully integrate physical and mental health services, which is very unique about our organization, and deliver improved health to our entire population, regardless of their zip code. So we were already talking about telehealth and telehealth expansion, since we are responsible for close to 450,000 children across the region. And we also have a lot of draw nationally and internationally. So how do we provide access to care? How do we make sure that there's continuity of care for a lot of these children and families who we serve? So our guiding principle was, again, that zip code should not decide the care received by children. It should be completely agnostic of their social determinants, their insurance status, and other barriers they might have. Uh, as it stated for Ohio, at least for our hospital, this is the only freestanding hospital within 34, 36 counties that is a tertiary care center with such specialty for pediatric region. But on top of that, their geographic distances, the majority of the South and Central Ohio is rural and very underserved. And that becomes an issue that the long distances that are required to cover are a major barrier, and telehealth could be an option. And then there is a barrier of weather. And if anything that I've learned in 2 years of my stay in Ohio, that the picture on the left with bright, skinny, beautiful sky, and picture on the right, when it's suddenly snowfall and the drop in temperature could all happen within a matter of hours, and we got to be prepared. And with that uncertainty also is a huge barrier for accessing care for a lot of our families and patients. And so we recognize that how telehealth addresses the gaps in this care. And so we were really working on almost a 3-year implementation plan. We already had existing telehealth within behavioral health, where we provided remote psychiatry follow-ups for the patients who were seen here but could not travel. And it was going great. And obviously, this guy occurred, and it really then led to us getting back in the trenches to figure out and innovate, because something like this has not happened in the last 50 years, 100 years. But one of the biggest catastrophes, as I said, became the catalyst for telehealth. And what we see here is that the achievement in the period of 3 weeks after the stay-at-home orders was much more than what we had planned in 3 years. So looking at the sheer volume of telehealth encounters and the numbers of clinics that went live, it is nothing less than transformational. To date, at least up to last month, we have had close to 230,000 completed telehealth. More than 50% of them are related to behavioral health. We also saw a very nice shift around a switch from just the telephone type of encounters, which were covered now during pandemic, to more and more video consults, so that we continue to have good fidelity when it comes to clinical care, and when it comes to making sure that the quality of the services that are provided and the elements that are needed, including eliciting good physical exam, eliciting observation of some of the symptoms and signs that you have to see when you make a diagnostic decision or treatment decision, were all done in a very nice way because of the transition of video. If we just think about the last month, the trend has continued. We have had close to 30,000 visits by telehealth. And a lot of that is also around clinical therapies, where you need a lot of intervention or help of an adult to perform that intervention. So even though the numbers for other services are low, it's not really a reflection of low adoption. It's really a reflection of just the volume that they have in general for their outpatient ambulatory setting. So all in all, this was a great and grand success that was done within a record time and followed the national trends, all because the world was not the same after March 23rd order. What was so different about it is that we had the capacity. We had all the pieces of the puzzle. We already had the technology in place, but we did not have the regulatory flexibility, and we did not have the reimbursements for a lot of these things that could have been done in the past decade, despite of evidence. In March 2020, when that changed, all of these things became possible. And that's why we say the world of healthcare is not going to be the same after this. If we talk about just the telehealth visits by month, because there will be many folks who will say, well, it was just in response to COVID and probably it's not needed or it's going to go down. Well, there's some validity to it, because telehealth is not a replacement to in-person care. and we have to really make it very clear to our colleagues, to the health systems, to the providers, and to the payers that it has its place, but it definitely enhances the typical continuum of care. So what have we seen in the last 2 to 3 months is a little bit of downward trend when it comes to outpatient visits for telehealth, and a little bit of more in-person visit. But it seems like it is going to stabilize at that level, where we will still see significant amount of ambulatory care, about almost 60 to 70% by telehealth, and 30 to 40% will convert back to in-person when it's appropriate. Good thing to share here is that if we look at certain specialty trends, and in this case, our behavioral health, for example, if we looked at the outpatient volume year by year, week by week, that at some points, even though the volumes dropped because of the pandemic and because of new implementation, which was very rapid, of telehealth technology, the volume picked back up within 6 to 8 weeks. And at some point, it was actually higher than what would be expected for an in-person visit. There are examples from several other service lines where the wait times were very high because of scarcity of the clinical resource. Their volumes were much higher consistently than their expected in-person volumes as well. So not only is it beneficial for the health systems from efficiency and financial and reimbursement perspective, it's also very beneficial for the patients who are now able to get care that would have been otherwise delayed. Another thing that we also saw was the sheer innovation, because nothing like that had happened before. We never had the need to change and adapt what we used to do in person in a virtual platform. And despite of doing an evaluation in a virtual manner and developing the tools to fit in the virtual platforms, the patient satisfaction were much higher than what we would usually expect and see in the in-person visits. So not only has there been a increasing number of volume now, which is stabilizing, there is a much higher satisfaction when it comes to telehealth visit. And this is just an example from behavioral health. Now, we also definitely learned some of the lessons that what we realized is it's really a true paradigm in providing care. Now, seeing a child in their natural environment is much more valuable and insightful for clinical decision making. The only downside in my practice that I've seen, that in addition to remembering their names and their sibling names, now we also have to remember the names of their pets, ranging from Billy the cat or Petunia the hamster. However, this has been a positive change as well. But one thing to reiterate again and again for the health systems, our colleagues, and the consumers is that it is not a replacement of in-person care, rather an enhancement of ongoing care. What we also learned was the pieces of the puzzle have always been there. The telehealth infrastructure, the ideal one, we just had it. We just needed to organize for that. And the changes that occurred regulatorily definitely helped us with that. And so we didn't have to prepare a lot from technical expertise and education perspective, because our colleagues, and I think a lot of membership of HIMSS, who are experts in developing the digital and technical solutions, either through our electronic health records or through IT infrastructure, already had all of the knowledge and the skill sets. And all we needed is to bring them to the forefront and make them the primary team members to help us take on this challenge. And it was a great demonstration. And we certainly give a lot of credit to our IT departments and our EHR departments for letting us do that. The second part was around innovation. Now, we really had to leverage technology to perform certain functions that we would have never thought would be possible using the telehealth platform. And what we looked at was much increased access in rural area, much better with regard to earlier diagnosis, much better outcomes as well, because now the no-show rates are low and they were actually getting the care. And hopefully we will see over time the financial impact that will result in cost reduction. But we also saw some challenges and limitations, which is going to be setting stage for why and where do we need to go. One was the network difficulties. That the sudden utilization of all the bandwidth, because it's not just the clinical care, but school and work and everything is now utilizing internet, did affect the quality that we were able to utilize in this. There was also privacy concerns. There are many families and there are many areas where there was not really a private space in the house where a patient could have a visit with their provider in a private way. And that was a significant concern, but particularly when it comes to behavioral health as well. Then the biggest thing, the blind spot that we realized was the disparities in access to digital technology. And as we move forward from no longer to not yet phase, we have to prioritize our efforts to address these challenges. And the pandemic also forced us to revisit some of our key questions and come up with potential approaches as we move forward as well. So that brings us to our first thing. We need to look at alternative models of care. And why is that? Well, that's because the gap between demand and supply is very significant. And despite telehealth, we cannot really meet the needs of increasing population with the current workforce that exists right now. So if we think about specialties like behavioral health, majority of the country has severe shortage of specialists. So even though we are able to reach somebody in the rural area, there are still patients waiting to be seen in person in your office. So it's possible that it becomes a zero-sum game. It's estimated that almost the average wait time at this time for seeing a behavioral health specialist ranges from 3 to 9 months. How is that acceptable? That is absolutely not acceptable. It's a missed opportunity that can change the whole trajectory of a child's entire life. And so we really have to think about different models of care as well, because otherwise it's going to be shifting the resources from in-person at one place to virtual at other place. So even if we are able to reach the child in the rural part, again, which is a positive, we also need to be very mindful that we are contributing to building some capacity. Second, we need to leverage the technology to build capacity. And one of that potential solution is to come up with a telehealth-based or digital tools-based ways of building that capacity. We tried that, something like that, where in collaboration with hospital and Partners for Kids, we attempted to put together a project ECHO for child behavioral health. What it is, it's a telehealth-based learning collaborative in a hub and spoke model where a multidisciplinary team at a tertiary care center connects with the primary care providers or the regional centers that are remote or in distant areas. It aims at democratizing the knowledge. So you don't really see patients there, but you discuss cases and you move the knowledge instead of moving the people. It also creates a sustainable system of care for the communities so that with the newly acquired knowledge and support and mentorship from tertiary care centers, the kids and the families can access the same quality of care without ever leaving the communities. And what we also achieve here is the multi-fold increase in the capacity of reaching these children through newly developed skill set and tools. Now, this is kind of how it looked like. We have a hub team on one screen, and we have the regional spokes that are on the other screen. And we would go through a didactic, but then we would discuss the cases. The goal is, again, to use a problem-based learning method and adult education principles to teach them how to, and not just what to, when a case comes to their clinic. And so what we would see is, instead of the case resulting in a referral to a tertiary care center, it would start with assessment and initiation of a treatment with the support of this team, which was a huge win-win situation for all of us. With that, if it could be done in a fun way, even better. If you could see the second screen, it's almost like Brady Brunch. We build a community, we talk to each other, we also talk about really bad knock-knock jokes just to lighten the mood. And for participation, you get the incentives of CME credits or getting the quality improvement project credits that are required for certification. So just by connecting at lunch hour once a week, not only do you build capacity, not only do you improve access to specialty care for children in your communities, you also get to build your own community of physicians and providers to learn from each other as well. With the project, we were able to reach about 38 counties and close to 75 pediatric practices in a matter of just a year and a half. And that's a huge impact when we think about all of the children who might now be getting the care for that. But it's not just about reach. Any of the pilot or a program is worthless if it's not evaluated. In our evaluation, we found statistically significant improvements in overall knowledge and competence for our primary care providers in managing behavioral health conditions after participation of Project ECHO. Not just that, because of our ACU structure, we were also able to look at the claims data and demonstrate that there has been a practice change in a way the medications are prescribed for these children. And this is just an example, but these models are easily replicable in many other specialties, including surgical specialties, where a tertiary care multidisciplinary team could support, mentor, and help the local teams who may not be as specialized to deliver the same quality of care. And this has only been possible only because of the technology. One of the inadvertent positive that came out of this activity was that the practices who were already participated in Project ECHO, which is very telehealth based, did not have any difficulty transitioning to telehealth practice in response to COVID-19. They felt it very comfortable. They were very used to it. They knew how to look at the camera, how to make that eye contact, how to build rapport. And so it was, again, a good testament of how technology integration in healthcare and newer models of care has been extremely helpful. So the next thing is we also need to look at alternative places of how we deliver care. And these are some of the examples, like primary care, homes, schools, remote hospitals. And you might always ask, why? We are a healthcare system working in the hospital or clinic settings. Why should we do that? And kind of the answer for that comes from Sutton's Law. Now, I know there's controversy whether William Sutton actually said this or not, but just to make the point, when he was asked, why do you rob banks? He said, because that's where the money is. And that's the same principle that we're trying to say here, that we need to look at these alternative places because that's where the kids are. So if we think about the primary care or remote hospital or homes or schools, there are many different ways that care could be delivered at different stages using different resources. And it doesn't always have to be a physician-based care. It could be follow-up care. It doesn't always have to be an actual intervention, but it could be a remote monitoring. It doesn't always have to be something being done by a healthcare worker. It can be done in collaboration with the school teachers and school nurses and administrators as well. Now, this is just an example, again, from behavioral health perspective as to what are the things that we could do. In primary care, there are many things, including Project ECHO. In remote hospitals, we could do triage assessments. We could do the consultations and create the treatment plans. Great examples are the teleneurology or telestroke practices, where time is of essence. And once somebody presents at a remote emergency room that is not very well equipped with the specialty resources, is seen, and with telehealth, if the consultation is done, then somebody's life can be saved effectively And it's very cost effective as well, rather than airlifting them and bringing them to a tertiary care hospital, which might still happen, but the critical time that is of essence there has already been lost in that process. So using technology could certainly be utilized for managing and maintaining care at remote hospitals. The home-based and school-based are also, there are several of those examples when it comes to behavioral health in particular. Now, other thing that we need to think about is we should think beyond just video. When we say the word telehealth, somehow it incites a certain image where we are thinking about a real-time, two-way, video-based communication. And that is kind of getting old. I mean, Jetsons creators thought about it in 1960s, and I think we should do a little bit better in 2020 for sure. So maybe what we need is a paradigm shift from the term telehealth itself to virtual care. Now, currently the modalities include real-time virtual visits, but then also remote patient monitoring, asynchronous store and forward technique as well. There are different methods that technology is integrating. Telehealth or virtual visit is just one, but now there are variables. People are coming in with all sorts of data using their Apple Watches and Fitbits and other things. And there are many other validated tools that could be certainly helpful in collecting that real-time data that would be much helpful in making the appropriate clinical decisions. Secure messaging, again, instead of waiting for the next visit with your doctor or provider, there are ways to communicate in a timely manner. That is a patient to provider one. Provider to provider ones are also really emerging things that we should think about. That includes e-consults, and Echo was one of the examples of that. There are implantables that remotely could be inserted and could be managed from provider to provider only without a specialist ever seeing the patient. There are also second opinion consults that could occur through a variety of methods, which would be much more efficient if we integrate technology into it. Now with the universal adoption of electronic health records, and now almost everything having a mobile application that goes hand in hand with a main software, this is nothing but natural and a low-hanging fruit for us to look at. So I would like to challenge everyone to kind of shift the thinking from just the video-based telehealth to truly virtual care. That comes us to the next point, that we need to evolve in order to improve access. And by that, what I mean is this, and we talked about this in previous slide as well, as to how do we think about the synchronous as well as asynchronous methods and modalities as we provide care. These virtual visits or consults or e-consults or second opinions are going to be the wave of future, where we could maximize the relatively scarce specialty resource that we have in order to provide that care to our patients right away. Next is that we need to be equitable in our offerings. This was a blind spot, for the lack of better words, when we talked about telehealth in the context of COVID-19, or even before that. There are significant disparities based on not just the income as noted here, but also on race when it comes to adoption of technology. And we have to be mindful that the most vulnerable population that could benefit from accessing care through telehealth may not have the access to digital devices, internet, or even money for data plans to begin with. It then becomes a fundamental flaw if they cannot use it. And so we really have to be thinking about being equitable in our offerings. And that's where some of the innovation in access to technology first, also, and then that to be an affordable technology first, becomes very critical when we think about it. And so again, technology adoption, technology availability, and technology access go very hand in hand if we really want to be successful in our mission of delivering care to the people who most need it. Next, we need to be outcome focused. And so we need to organize in a way that this modality is used towards achieving certain outcomes and not used just for the sake of it or just because it's hip. It is through these predetermined outcomes that will influence the way services are set up. And outcomes need not only be related to health or need not be compared to in-person visits, but rather a true set of telehealth and technology specific outcomes. And so this is an example how when in 1990s the Institute of Medicine report came out around crossing the quality chasm, they talked about this thing as well, that the problems are not really because of the failure of goodwill or effort or resources, but the fundamental shortcomings in the way care is organized. So some of the examples of key quality metrics that we can think about in this case are the patient and provider satisfaction, or to go a step further and just call it the patient and provider experience. Because satisfaction is a very relative term, and we really have to first solidify what the experience is like in order to really improve it. Reliability of the diagnosis and the diagnostic errors that might occur because of technology adoption. The outcomes of implementation, cost effectiveness, treatment outcomes, and then most importantly, that health disparities in telehealth as well. The last point is that we really need to organize and support the academic centers of excellence that are focused on telehealth. Telehealth is not a separate, or virtual care is not really a separate service, but it's a modality, it's a platform, and it's a venue that is now going to be well utilized for doing what we have always done. So it's very important that we use the interconnected, intertwined levers of any academic institution to move the field forward. That includes education, research, and clinical service. And this is an example of how, if we were thinking about a virtual care strategy moving forward, how it would look like. And this is exactly what we are now doing within behavioral health at Nationwide Children's Hospital. Lastly, we have to keep the spirit of continuous quality improvement as we progress from first step to second, to ensure that what we do is truly improving the lives of families that we serve in the quality of care that we provide. And these four pillars could be very key. It's not just the technology and connectivity, where your membership is so critical and important, but a buy-in from healthcare systems about its significance as a distinct venue and an integral part of, in a way, which healthcare is going to be delivered. But also keeping us honest and grounded with quality and sustainability related metrics so that we are always focused and outcomes oriented. And lastly, it should be equitable, and digital literacy and access should be key for all of these. So with that, I'm going to stop talking and open for questions. Since there are a lot of things that we think where we should be, how we should be, but what are the steps that are needed to be done, and what are the things that you are doing in your organizations would be really key and valuable for this part of the discussion. I'll stop sharing.
So if you have any questions, we have a chat box that you could put your questions in. Sometimes we have a Q&A, but mine seems to have disappeared. So if you would be kind enough to put any questions in the chat, and just to sort of kick that off, I'd like to say, first of all, I'm really proud to be in Ohio where we have a facility like this. So thank you for telling us about that. And I'm very thankful that you have as a determinant, zip code should not determine your health care. And I wondered if you could speak to what it means for a patient being in state and out of state and how that might affect access. And if you could secondarily speak to, there's been some literature that teenagers in particular are more revealing when they are on a screen, they're more honest. It's like a more real experience. And so if you would be kind enough to address that, hopefully, I see we have some questions coming up. So I'll be silent now.
Yeah, great. No, those are great questions. So I'll try to address that one by one. So first is in-state versus out-of-state. Prior to COVID or prior to telehealth, obviously they used to travel. Now they don't have to travel and we can connect. However, there are very specific requirements that are more related to both reimbursement as well as the regulations around licensure. So in order to provide care for a patient across the state line, a physician need to have a license in the state where they are, as well as where the patient is. And you cannot really practice medicine across the state line unless there are arrangements. Now, there are federal medical state boards, FSMB. They have created a pact of about 16 to 18 states where there is portability of licensure. And that a physician can practice in any of those states, even if they have license in one. However, we're not part of that yet. Good thing is with the pandemic, each of the state really pivoted very quickly, and they adjusted their regulations and allowed up to certain time, up to certain limit, with appropriate notification to the respective state boards. It's still a little messy, but it's allowed. That way it doesn't cause unnecessary burden, both on the health systems as well as patients for that. What the membership of this organization could do is really then looking into a really good things like geospatial recognition, where they are, because right now I can tell you that I'm sitting here in Columbus at Nationwide Children's Hospital with my virtual background, but it's very possible that I'm currently sitting in a bathroom at McDonald's and you wouldn't know. So that it does have a lot of those implications where we really have to be dependent on and relied on what information the family is providing us. They might say we are in Columbus, but they are vacationing in Florida, and we were the ones who would get in trouble. And they probably might also get in trouble for their insurance not paying for their medical bill as well. So that's kind of a long-winded answer. It's a little complicated to put it short. The question around teenagers being more revealing, oh, absolutely. On an average, a teenager checks their phone 540 times in a day. On an average, a typical teenager is hyper-connected to about 14 hours of a day. The teenagers, they don't hang out anymore where they are going to the park or meeting at a gas station or a food place and to cause some trouble there. But now they hang out virtually and they are either FaceTiming, they are on their video games connected with each other, and that's the way they are extending their social relatedness. And imagine if somebody like your doctor, a healthcare provider, a pharmacist, a counselor could also be part of that milieu and who's also cool to be in that. There's nothing better than that. And so that's absolutely true that this distance puts a little bit of psychological safety because of that distance barrier and the video, as well as them being in their home, which is a very predictable, safe, and natural environment for them as well. Good thing is a lot of times it's a great rapport builder that there's no formality, because otherwise it's really awkward to talk to a strange adult, man or woman, in an artificial environment where you have no control over and talk about all the intimate things, including physical complaints and mental health complaints. Whereas here, if you've given a little bit of power to them, we have had some incidents where when our doctors struggle to deal with the volume or setting of the video, the teenagers walk them through how to do it. And that gave them a little bit of control, and that put them at almost a equal partnership relationship, which is a very, very important in this healthcare environment as well.
Well,
So there's a question I think is about requirement of recording the telehealth session for billing and or compliance review. Uh, the crude, simple answer is no. I think because it then leads to storage and ownership of that video. Um, Generally, you're prohibited from recording the clinical interactions, and we had seen the security concerns with like the Zoom that had occurred and how some of the recorded therapy sessions were accessible and were put on. So there is a lot that goes into that information security and end-to-end encryption. But in general as well, it's almost like creating a shadow chart if you're recording a session. And then where do we keep it and how do we store it and who owns it? Those are still things that are evolving. So right now, that's not allowed. However, there are ways of communicating through recordings. For example, recording a tick, recording a behavior, recording a particular abnormal movement or an event like seizure, where a parent could record as it's happening and they could send asynchronously in a store and forward method, so that instead of trying to describe it, they could share the short recording clip that a physician can review and provide opinion or provide some guidance around that. Same goes with pictures or digital images, like a cut, a bruise, or skin condition, or eye pink, eye redness, and things like that. Those are occurring in store and forward method. What is needing to change is those are the things that happen, and we do it just because. Even though there is a time involved, there is information system involved, there is expansion of the capacity of the electronic health records that is involved, and there is a physician valuable time involved as well, but none of that gets reimbursed. So the consideration number 6 around we need to think about alternative ways of doing things through these e-visits, that's kind of the thing that we need to probably focus on from both video and image question. But that was a great question, by the way.
And it seems like the next question adds on to that a little bit about adding the GPS to the virtual visit for licensure liability challenges or privacy risk with that. And I would add to that question, in our location in Cincinnati, we consider ourselves a tri-state region where we consider Northern Kentucky and Cincinnati really one organization. There's a lot of people live in one place, work in the other, go to school in the other. So in our sort of cultural mind, it is one place, but it is different. And you pointed out the licensure issues. So I would be very interested in your opinion about how GPS might protect a physician from getting in trouble with that and how it would work with the reimbursement.
Yes, I think that's again a great question as well. First is with regard to reimbursement piece. Obviously, the insurance is through their state, and the payer is in that state. We need to make sure that you have a contract with that insurance provider about the telehealth coverage. Second piece is from licensure and liability perspective. You still cannot provide care across state lines unless you have that arrangement, unless there is a permission from the state as well as medical board. So there are multiple regulatory boards and agencies that come into play. And so having a GPS or geolocation system be part of virtual care, I think is already happening. I think some platform or some companies are already using that technology to locate where they are, particularly if these are the non-established patients. If you have never met them, this is the first time you're seeing them, and they're saying that they're there, but who knows, and how do we ascertain that? It's also important from contingency planning perspective. We absolutely need to know where they are so that if there is an emergency, when you call 911, it's a Columbus City Police or Columbus Fire Department or Cincinnati Fire Department is going to respond when you call 911. We need to know where they are so that we call their local number. And that's why it's very important to have that as part of the consideration when it comes to contingency planning. So GPS, can it become the part of virtual visit? Yes, it is already there. It's more about adoption everywhere based on resources that we have.
Wow, that's absolutely fascinating. So Are there any other questions? We'll pause a moment if there's anybody that would like to put a question in the chat box. Here we go. A follow-on question to recording. Would a transcription text capture for the session, which would help with billing code and charge capture?
Great question. And you probably might have heard um, very recently, one of the big electronic health record systems came up with live transcription that could occur as you are in a patient encounter. That is already occurring. So either it's an external text-to-speech transcription device that you use to record during that transcription, during the encounter, which generates the note, and all you do is edit and do it. That's certainly happening. For charge capture, I'm not sure what you mean by with that. If you mean that, could it be an additional, like, are you able to charge additional, say, facility or equipment fee? Currently, I don't think there is a structure for that. However, where it could be really useful for billing code and charge capture is that maybe it could be helpful in meeting all the required elements of your visit to make sure that it's compliant. And text-to-speech and kind of audio recordings could be super useful in that. But again, those are very live kind of transcription based softwares that are available. Does this answer the question, Mr. Chan?
I see there's, has Nationwide enabled video upload for my chart or just images? And another sort of related question is, will the tool for information exchange require specific devices? So video upload to my chart at Nationwide and specific devices for information exchange.
Yeah, so we can have the images sent through my chart. I'm not sure about the videos yet, but I can certainly find out. Images has been going on for quite a long time. What positive thing that we saw here is, in general, the penetration of app-based tool like MyChart was very, very, very low prior to COVID. But because now we took a very strategic decision to take the sustainability into consideration, where even though the emergency ruling says that HIPAA is waived and you can use whatever, we decided to stick with all the privacy and security considerations. So we did set it up in a way that there's no way to connect to a video encounter. There's no way to register unless you have MyChart and you go through MyChart, which I think in the long run is going to be extremely useful, because now nobody has to change anything. We just needed to do a little bit of work on a front end, and now everything is very smooth and adoption is high. So even though we improved the penetration for video visits, now folks are using it for all the other things, like sending images and like sending messages and asynchronous communication and store and forward image transfers and things like that, which I think was a huge unintended consequence of that. What we probably need to do is continue to track and collect data and show the value, that it's actually valuable, and then put it with a dollar sign that it should be reimbursed, because it's a really significant investment of clinical time as well as the infrastructure, particularly IT infrastructure time, and that there should be a way to recoup that through RBS system. Will the tool for information exchange require specific devices? Could you please elaborate on that a little bit? I'm not sure what is being asked, Joseph.
Just that some tools that let's say will require a Mac or a Windows, or let's say a certain, I don't know. I'm just saying that usually some devices doesn't support some tools, so I'm just asking that.
Oh, gotcha.
Yeah.
Yeah, I see what you mean. Yeah. I think the trend that we're seeing is more and more cloud-based, where you're not really downloading or storing anything in your local device. So at least on the patient end, those things still apply to us on our end as a health system. But on the patient end, probably that's not going to be the case for that, as far as what we have seen. But I can try to find out more if I understand it a little bit better.
Okay, thank you.
So we have ourselves now at 11:55. Are there any final questions? Any final questions? Okay. Dr. Ramtekkar, this has been fascinating and so enjoyable. And we really appreciate your time and sharing your expertise. And we're very happy about the things that are going on in Ohio in terms of telehealth and working with children. So we thank you very, very much.
Well, thank you. Thank you for having me. It's a great group, excellent questions, and I'm sure that the role that your membership has played into the successful adoption of telehealth and improving access to care is going to get bigger and more important. So thank you for all of you that you do.
Thank you so much. And so for all our attendees, you were given an email document today. And so now that we're done with our 11 o'clock breakout session, we're going to switch over to the 12 o'clock. So that's going to require us to get out of this one and move to the next meeting. So again, thank you so much, Doctor. And we look forward to seeing everyone at the 12 o'clock session. Thank you.
Pleasure. Have a good day, everyone.
Thank you. Bye-bye.